donation in general. We want to be able to support you guys and make sure that you have all the tools that you need to be able to succeed when a donation case does come up here at Memorial Hospital of Sweetwater. It's such a long name. I'm like, this is such a long name. I just want to call it Sweetwater Hospital, but that doesn't work because it's Memorial Hospital of Sweetwater. Anyway, so we're going to talk a little bit. Can everybody see this okay? Should we turn these lights off? Might be a little bit better. So first, just kind of to talk about donation in general, kind of break up the ice. Like, we don't always want to talk just drill about education of what donation is, but I kind of collected some stories from 2015 of great donation events that had happened in the nation, the trending social media, because that kind of drives the world lately. This woman in New York, she donates every year to a homeless shelter that specializes in having women and children, and every year she donates some toys to the children. This last year, in 2015, this toy store was going out of business, and she walked by and she said, I'm going to buy the entire toy store and donate it to this homeless shelter for these children. And she did that, and the homeless shelter was amazed and set back by the profound donation she made and said, I've never in my life seen anything such a big donation to this organization, and we've been around for 20 years. This is amazing. And that was a donation of toys. Pretty remarkable. This teen, she is a cute 13-year-old. She works volunteering, because I can't say she works at a 13-year-old, but she volunteers for a women's shelter that specializes in abuse situations. So they take the women and the children and give them a place to stay, safe haven. They had a gala, a big gala to represent all of their volunteers, and she was invited to come. She was expected to receive the award for the most volunteer hours within the year. And she was excited to do that, and the gala was held. They had a raffle for this Chevy, and she just entered, and she won it. And she thought that was amazing because she turned around and gave this Chevy, $70,000 car, back to the shelter so that the families that were living there that had nothing actually had transportation so they could go to the grocery store and take their kids somewhere. And so it was given back to that shelter, which I think is so profound. A 13-year-old seeing the need, seeing a deficit, and fulfilling that because she didn't need it herself. And I thought that was interesting. This guy is in Colorado, and this is kind of interesting to me as well because so he and his dog are homeless, and the reason why they're homeless is his house burnt down. Well, I can't say burnt down, but it burnt where it wasn't livable. And the insurance company was disputing the claims at this time, so he had nowhere to be, and he had no money. And so him and his dog were homeless, sitting on a corner in this huge snowstorm that came by. It was, oh gosh, what was it, the beginning of December? We had a massive amount of snowstorm in Utah that swept all the way across, and you guys got it too. And this is that snowstorm. So the guy saw all these cars getting stuck at this particular intersection, and he pushed out probably 10 people that morning on their way to work. And one of the people that he pushed out was so moved by that action, like you got out of in the snow. You have no way to clean yourself, no way to dry yourself, and you helped me get out of the snow when I have a clean, dry home to go to and I'm in a dry car. And so he started a GoFundMe page, which we all know there's a million GoFundMe pages out there at this point. But he put it on and called a local news company and said, I want to recommend you recognizing this gentleman that helped everybody this morning in the snow. And I just want to recognize this so that he gets some attention. He is in need of help. Why can't we help him? And that GoFundMe page that hit the news raised $23,000 to help him get back into his home, just because he had that effort to make a point of helping others. So I thought that was an awesome story. This is actually a Utah donor in Park City, which they have this is an old picture, but it's the picture of the apartment complex, and it is designed for low-income people who are on assistance. And during Christmas time, there was an anonymous donor who donated $25,000 to help people during Christmas time pay the rent so that they could take that money and do other things with it for Christmas for their children or their family. And I thought that was pretty amazing. Anonymous donor. And it hit the news just because it was anonymous during Christmas time, and somebody just decided that that was what they wanted to do with their money. I don't know if anybody recognizes this. It was huge trending on social media. This actually happened in this year, just in this month, just about 3 weeks ago, the beginning of January. This woman in Chicago, she's walking down in the subway systems going to a game with her husband, and she had geared up, nice and cold, had tons of Under Armour stuff on, and through the time she went to the game and came home, on her way back she kept stuffing her layers into the bag she carried, and she passed a lot of homeless people because they all kind of migrate to the subway, and didn't think anything, and she saw this lady crouched down on a street corner, and she was just really drawn to her, and she looked at her and she was so cold, and she's like, oh my gosh, she's freezing, and I have all this warm clothes, and she has nothing. And I have this bag of warm clothes that I had taken off. So she ended up walking over to the lady to give her her bag of warm clothes, and she saw a sign the lady was holding that said, all I need is something warm, please help me. And it was just ironic, and it was so profound to this Chicago woman riding the subways that she was drawn to her, and that's exactly what she needed, was her warm clothes. She gave her her bag of warm clothes, and then she looked at her boots, and these are actually the homeless lady's boots. The lady who, Kelly McGuire is the lady, she posted this picture of the boots. And she looked at the homeless lady's boots that are not very, they have a hole in them, they're wet, they're not waterproof. She's in Chicago, it is soaking wet in the streets all the time this year. And she looked at her own soles, her own waterproof sole boots that she just got for Christmas actually from her husband, and said, you need these more than I do. And she took them off and said, you need to take these. And the homeless lady said, I have nothing to give you but my boots, that you can go home and so you're not sock-footed. And so she took her boots and she wore them home, and she was just humbled by the experience of something that you can give to people to help. And it was something that was old and used, but it still helped her, and it helped her kind of realize the profound impact we can have on each other if we allow it to happen. So with those donation stories, I'm going to go into organ and tissue donation. So this is the Utah Donor Registry. Wyoming has a registry as well, and I just kind of want to touch on what a registry means. The Anatomical Gift Act was first established in 1968. Dr. Barnard was the first successful person to do a heart transplant in 1967. That stemmed an awareness of organ and tissue donation and the need for it, and the need for the organs. And so the legislature came together and wrote the Anatomical Gift Act in 1968. It was revised in 1987, and then again in 2006. What this basically states is that if someone is registered donor with their state, that is their intent to donate. That is their voice to say, I would like to donate. Because when they're in the bed and they're actually to that point of making a decision of donation, they don't have a choice, they don't have a voice. And this is the way that we can offer our voice. So that's where the registry stands and why it is a legal aspect in donation. We at IDS, Intermountain Donor Services, we're dual advocates. That's what we consider ourselves. We're trained as dual advocates. So what we're doing is we're advocating for that patient in the bed, for what they said they wanted done. And we're also advocating for the potential recipients of the organs or the tissue that we can procure. We also take it to another level, and we like to advocate for the family members. That is a big, big piece of this. And there's some dispute. So let me just ask you guys, when you're on the registry and you're, let's make it about me, and I'm on the registry, and I have a horrible accident, and I'm brain dead. I herniated. And my husband doesn't want to give my organs away. He just doesn't feel that's a good thing. He's actually part Indian. His Indian heritage, which he's not believe in, but this one piece he really does believe in, he believes you go to the ground whole. So he doesn't want my organs donated. I always have. I've been on the registry since I could be when I was 16 years old, and we'll talk about age with that too. But who has the say? Who has the final say in that? Would it be my registry stamps, or would it be him saying, I don't want to donate? How many people think it would be his option to say, don't donate organs? and others for the registry would stand. The registry actually would stand. We legally can take action to say they signed over, they want to donate, we're going to move forward. However, IDS is a little bit more conscientious of family needs, and we actually talk to the families. We don't just come in and say, hey, hands off our organs, our tissue, because that's not fair to families, and they're already experiencing a tragedy. We don't want to do that. So what we normally do is we'll come in, we'll explore emotions, we'll talk about what their reservations are about donation, we'll talk about what the registry means and what their loved one probably wanted by signing up for the registry, and then we let them think about it, and we talk about it. And we have never, in the existence of IDS, ever had to make a choice that we're going to pursue legal action over a donor case. And we hope that never happens. We really want to make that happen. There are cases we've walked away from because of emotional turmoil in the family. That's not very many either. It's probably 5 in the existence of IDS. Because most of the time, they're coming from a place of emotion, and if you give them time to process, they really realize this is why we have a registry. It's because the family can actually give them a chance to stand and talk when they can't talk anymore. So, any questions about the registry status? So, age is a factor. Everybody gets their license, not everybody, but most everybody gets their license at 16, and it's actually asked at the DMV when you go sign up. 16-year-olds are not, they're minors. So by legal aspect, that isn't considered an intent until they're 18. They don't have to re-sign up, but it is considered intent at 18. Below that, it is the parent's decision. So that's the one exception to that. So, any questions? All right, so we're going to talk about the types of donors. There's 3 types of donors, and there's really only 2 types of donors, organ donor and tissue donor. But there's 2 types of organ donors. So we're going to break up those 2 and kind of talk about the difference between the 2. So with an organ donor, there's an organ donor type 1. I didn't put a type 1 because there shouldn't be a type 1, type 2. I just want you guys to understand there's actually 2 different ways to have an organ donor. The first way is we have a ventilated, heart-beating, brain-dead patient. The patient must remain on a ventilator until all organs are recovered. They must meet brain death criteria, so their EEG is flat. There's no response from their brain. There's no waveforms. Their there's an angio performed. There's no blood flow to the brain. You can see sometimes in the brain stem, but it doesn't come up, and I'll show you a picture of that, come up to the brain. They're considered clinically brain dead, or neurologically brain dead. Another thing about brain death is that it takes time to reach brain death sometimes, depending on the insult. So a good example of that is a hemorrhagic stroke. Hemorrhagic strokes are not brain death initially, but there's bleeding in the brain. Brain and blood don't get along unless it's in the vessels. And so the brain is uncomfortable, and it swells, and it reacts to that blood against the tissue. And in 4 days, 72 hours, 3 to 4 days, we reach max swell, which we also usually reach herniation, which then we're at brain death. So sometimes we'll have a donor sit on a unit, and we'll manage them medically to help support the process of brain death so that we can achieve a brain death organ donor. And the reason why is because there are more organs available if we have a brain death organ donor. And we'll go into that in just a few minutes. The type 2 organ donor is what's called a donor after circulatory death. So that's a cardiac event. And it doesn't mean that the initial insult was a cardiac event. It means that they're not brain dead, and they're not going to achieve brain death. They had maybe they had a suffocation, a drowning, a hanging, and they had an anoxic brain injury that's not recoverable. But that's not going to produce a brain death donor. But they're not going to live. So when we withdraw support, like we withdraw a ventilator, we take pressors off, we're going to have that patient expire. Once that patient expires, that's when they can be a donor, because it's after cardiac death, their heart has stopped. So this is the vented, heart-beating donor. So the heart has to be beating when we're called. Like this is part of the reason why referral process is so important. we'll go into more detail about referral process. The patient has a non-survivable injury. We've already touched on that, but they don't meet the brain death requirement. And this is a tricky one. The patient must pass away within 120 minutes after extubation. So that time frame is actually set by the transplant centers, whoever's receiving those organs, potentially. And they're allocated before we go to OR. So if a transplant center says, yes, I want the liver, but they have to pass away within 30 minutes, then that's the defined time, not 120 minutes. 120 minutes is the max. We can have a transplant center define 30 minutes, 60 minutes, 90 minutes, or 120 minutes, or anywhere in between there, but the max is 120. So it's kind of discerning, because when you think about 120 and then you go into a room and they say 30, you're like, wait a minute, you guys said 120 before. That's only a rough guideline, and then the transplant centers actually set the hard number. So don't let that 120 stick in your head as the number. It's just the maximum amount of time that has to pass. If they go and we extubate the person and pull all support, and they are 120 minutes, they're not an eligible donor. So we also look at our donors before this happens, and we do trials. We do CPAP trials. We do apneic trials, and we see if they'll breathe. Because we need to know if they're breathing 5 times a minute, 2 times a minute, or if they're breathing 18 times a minute. If they're breathing 18 times a minute, they're not going to pass away within that 120-minute guidelines that CMS has defined. And that is defined by CMS. The transplant centers can take anywhere under that. Does that make sense? So we do a lot of evaluations with someone who has the non-survivable injury and do not meet brain death criteria to determine eligibility. And we want this all done before family is contacted, because we don't want to give family any false hope of donation if that's what they really want. A lot of people find a platform to heal from being able to donate their loved one's organs. And if we give them an option of donation and then they're not eligible, it is another kick to the knees that they don't need after they've already experienced some turmoil in their life with losing a loved one. So with that, we always ask that you guys talk to us before you talk to family. And we don't just ask that. It's actually CMS Guidelines. The approach needs to be made by a designated requester that is specifically trained to do so. And all of our IDS people are that way. Secondly, we also need someone that can evaluate the medical side of donation before we make a decision whether they're eligible or not to even approach the family. We'll talk a little bit more about approach. The third, which says 1, that's funny, it changed it for me. But the third type of donor is a tissue donor, which is where you guys actually excel. You guys have so many tissue donors come through and not as many organ donors. We're going to work on trying to educate a little bit more about the difference between the two and how you guys can increase both numbers for your hospital. So with tissue donors, this is a non-heart-beating patient, so they can be expired. They are eligible to donate 8 to 24 hours after they have expired. So that's something to keep in mind. Just because someone has passed away does not mean they cannot be a donor. They can be a tissue donor. And then they actually are eligible to donate their skin, full thickness and partial thickness skin, bone, vessels, heart valves, and eyes. So the next little picture that I want to give you guys, and I know it's a little bit graphic, but all medical personnel should be comfortable with looking at this. This is the difference between a brain death donor and then a DCD donor, a donation after circulatory death. So why we want to wait those 72 hours to max herniation for those patients is because the option of being able to transplant all of these organs is so much better than being the option of 2 organs. So with a brain death patient, we have the option to transplant lungs, intestines, heart, kidneys, that can go to 2 patients potentially, liver, that can go to 2 patients potentially, as well as pancreas. Pancreas is one of the lowest transplanted organs because it is so tender and not a very workable organ. Sometimes you can touch it and it just like shrivels. It's just not a very comfortable organ to work with for itself. And so when we get a pancreas, it is celebratory. Secondly, don't know what happened. There we go. Hit a button. Secondly, lungs are kind of hard to procure sometimes, same with heart. So this is what I meant on the other side, like that brain death donation can take time. So say we did have an automobile accident. The patient came in herniated. We know they're already brain dead. But they also, in the meantime, coded. You guys were able to bring them back, which is good. And why would you want to bring them back? Because they're herniated, the potential for donation. So, and we can't evaluate that at that time, but you have to work for being able to offer that. And the ED docs should be able to do that, and they all have the mind frame to do that. They want to be able to succeed in one way or another, even if it's donation. So the herniated patient had the MI, or coded. You guys survived that patient. And then we look at things and they're registered and they want to be a donor. And we've been through all of the process and the family has consented and said, yes, we're going to donate. And so then we do testing and we do an echo. And the echo reads that the heart, the ejection fraction is only 35%. And that's because of that code that was ran. That 35% heart, or ejection fraction of that heart is a non-transplantable heart. Nobody wants a 35% ejection fraction. We want 60s, 65s, right? So what we can do is we can actually work on that heart to get it to become more sustainable. We can give it T4 to help with the myocardial function of the heart. We can treat with fluid, or we can treat with removing fluid. It all goes into that circulatory process of the three contributing to heart beating: the fluid, the contractility, and why am I drawing a blank? Fluid, contractility, and the electrical function of the heart. So secondly, when we are able to treat that heart, a few days later, we'll do an echo, 2 days maybe, and we got an ejection fraction of 65%. And so we were able to transplant that heart because we were able to recover that heart from a 35 to 65%. Sometimes that's what takes time. Other times are lungs. Lungs are also hard to procure. Usually when you're in a trauma, people throw up. They inhale some of that. It becomes part of their lungs. And then it sits there and gets infected. They get atelectasis because they're not turned as often as they need to be. They're on the vent. We can't control those things. We try. We have a million tools in the bag, but sometimes it's not preventable to cause or to have a little atelectasis after a great trauma. But so lungs like that are not really transplantable, but if we can put them on a roto bed to turn them back and forth and sometimes prone them to help with the gravity and help pop those lungs back open. We have vent settings that we use. We use high peep settings for 30 seconds at a time, 30 a peep, to pop those alveoli back open. We also utilize APD modes and ventilators. It depends on the lung surgeon, like who wants the lungs, if they're going to do APD or not. But those are some options that we have, so we can actually turn lungs around so that we can get a transplantable FiO2 of 350, where before, 3 days ago, we were only at 200. And that's kind of why we take time with brain dead transplantable organs, because we want to be able to maximize the gift that's been offered. So instead of being able to say on day one, we know you're herniated, we know you're dead, your patient, you're a registered donor, this is what you wanted to do, your family wants to do this, we're going to move forward and we're going to go to OR today. And all we can get is kidneys and liver, maybe pancreas, but that's that tenuous little organ. Intestines are the lowest transplanted just because the need isn't as great. So we've only really achieved a DCD donation. If we give the patient time and we give our coordinators time with your nurses being able to work on getting the heart and the lungs, we were able to transplant 2 other people. So that's kind of why I want to explain why brain death donors can sit on a unit for a few days before you guys have that experience. I don't know that you have or you haven't, but as low levels of donation, organ donation you guys have had, I assume you guys haven't seen that. I know you haven't seen that in this year. So some of the feedback I get from nurses in hospitals that do a lot of donation, they don't understand why the patient is sitting there for 4 days. They've been herniated. Why are they here for 3 or 4 days before we go to OR? Why? Why does this have to happen? And it really comes down to making the most of their gift and making sure that more organs are transplanted. We work with the family with this. We let them allow a time frame, how much they can handle, because you can only handle so much. And we continually check with the family. The coordinators call family personally and talk to them personally all the time to make sure they're doing okay with this process. If they're not, we're totally happy to stop, and we'll move forward to donation when they're ready, and we'll be grateful for the gift of kidneys and liver. But we like to offer that option to the recipients that are waiting, the potential recipients, should I say. So with DCD, we don't have the availability to do lungs or heart, because that's where the death has been caused from. It's a cardiopulmonary death. And usually, because of that, there's some injury, and we can't transplant that organ into somebody who's already sick, usually, an injured organ. So that's why heart and lungs are out. In California, sometimes there is one area, St. Joe's, that they're transplanting lungs that are DCD. It's very rare, and it's just started, so we might see that in the future, but I don't expect it anytime soon. With DCD, we have the liver and the kidneys, and there's called warm ischemic time and cold ischemic time of organs. Warm ischemic time is after the heart has stopped beating, the blood has stopped circulating through the organs in its stasis, and it hasn't been lavaged yet. We have perfusionists that actually, after the blood has blood flow has stopped, they'll take a special solution. It's kind of like an LR, but it has protective agents for the organs in it, depending on which organ. And they will flush out the organs, sometimes with heparin as well, so that there's not blood clots. And they'll perfuse the organ with this special solution, and that's what's called cold ischemic time. And it starts from that time where that blood is removed and that organ is cold. We also have what's called pumps that we can put kidneys on, and kidneys can be pumped for 24 hours before they're transplanted. And that's also with that special solution. It's actually a special pump that puts it through the kidney to keep everything patent and running. It's not blood, it's not oxygen, it's no nutrients, very little nutrients, but it's just the idea to keep that blood, or that kidney open and flowing. And then we can transplant that. So kidneys have a little bit more time. And sometimes, like hearts, we have a 4-hour window, so we have to allocate that really close by. But kidneys, if we're expending our local list and we are not finding a match, then we'll extend that to find a match, because we don't want to waste organs and we want to be able to transplant what we have. With liver, our transplant surgeons are getting very picky, I guess is the word, but they're picky for their patients, and they're picky due to research and what research has shown, because we all revolve around evidence-based practice. And it shows that there's delayed graft function when a liver has had almost any amount of cold ischemic time. So they're not as apt to take a liver in a DCD case. It's most likely just kidneys, which I don't want to downgrade just kidneys, because kidneys is the number one need on the transplant recipient waiting list. The number one need is kidneys. Secondly, to give you an idea of how many people are on the transplant list at the beginning of the month, it was 102,000 people on the transplant list waiting for organs. And there's such a deficit because we don't have a lot of organ donors come through. We don't have a lot of registered organ donors. Well, I mean, then we do have a lot of registered organ donors more than not. But if they're not registered, that doesn't guarantee a donation. Secondly, it doesn't guarantee a donation if they pass before we're able to do that, which you guys actually experienced this year. We'll kind of talk about that case. So any questions about the organs and where they go and why we take time to get them to work better for the patients that are receiving them? Okay. If you guys have questions.
Yeah. So these aren't just adult organs, these can be pediatric and infant organs?
Yes, they can. So actually, with this next slide, this is the brain death angio. This kind of shows you that brain testing, just to give you guys a visual. But this next slide kind of talks a little bit more, oh, I went too far. There we go. This next slide actually talks a little bit more of the specifics of brain death donor. So the qualified donors can be from age 0 to age 80. We do roll out at 80. Doesn't mean that you guys don't refer. If you get an 84-year-old in, you still are required to refer. We just have to evaluate, and then we have to be the ones that say they're not eligible. We can't have a physician do it, a nurse do it. It is actually by CMS Guidelines. IDS organ coordinators are the only people that can rule out an organ donor. So if they're 84, you still need to call. But that 0H is actually, they have to weigh at least 6 pounds. So that comes to OB. We've done anencephalic cases. Everybody's aware of what an anencephalic is. If you're not, it's fine, because if you don't work OB, you don't know sometimes. But we have these beautiful angel babies that are given to these moms. And the moms sometimes, this is one of the hardest diagnoses to hear, is your child has something that's incompatible with life, and that's the term. And just this last year in Idaho, we were able to donate with an anencephalic baby. Mom decided that it was something she strongly wanted to do. We worked with her from the moment she found out that the baby had a disease process that was incompatible with life, and we stepped her through that. She's the person who came to her OB to talk about organ donation for her baby. They don't have to carry baby to term. They can terminate. There's no reason to carry baby to term because it's going to be terminated upon birth usually. And I know that sounds cold, but it's the truth, and these are the facts of it. But the truth of the matter is this woman, and we've done more than this just case, but this is just the most recent case that I can talk about. She made the choice to carry that baby full term, to birth that baby so that her baby could help other babies and give life to other babies. And it's interesting because with a baby that size, they do have to weigh at least 6 pounds, but they can take organs from that baby, like the lungs. They usually aren't transplantable because there's usually a brainstem issue, and this particular baby had one lung that never inflated. So it had one full lung and one lung that never inflated, but they were able to take those lungs and give it to research, and they are researching on cystic fibrosis, and they studied to get cures for cystic fibrosis. They use heart valves very often in babies. Heart valves are donated, and that's a tissue donation, but some babies don't have workable heart valves, or they were born with floppy heart valves, or they have no tone, so they can take a baby's heart valves that were grown perfectly, and that baby didn't survive and give life, extended life to another one. The liver, it's interesting because they actually can process the liver, and they make it into a paste, and they take the hepatocytes from it, and they make it to a paste, and they inject that paste into the liver. So they're not transplanting a whole new liver into a baby that size. They're injecting a paste of the liver cells from the baby that's liver was healthy. And those healthy cells go into the sick liver, and sometimes they reassign cells. And there's been cases where just from that paste, that child doesn't need a liver transplant ever again. Like their liver is fixed. So there's so much power in that as well. And that's why I thank you for coming from OB especially, because sometimes people are unaware and they think they're too small. And they think because the recipient is also that small. But oftentimes the results, and kidneys are very transplantable with babies. Some babies are born without kidneys. So we would like to be able to give them a kidney that was grown perfectly for them and couldn't have ever worked for the baby that was born, unfortunately. But that's a good point to make. So with brain death donors, and that would be considered a brain death donor, and it's a little bit different with apneic babies, or with anencephalic babies. They have to be born alive. They can't expire during the birthing process, and they have to be able to breathe on their own, at least take a couple breaths. And then we intubate, and we support that baby until the parents are ready. Because we don't want to not give that bonding time to the parents. And there's a difference between a warm intubated baby and one that's not. And so we are very conscientious towards that. And the organ coordinator that is prime on this, like we have actually 8 who are in training right now, organ coordinators. But there's one that will take any of these cases, the baby cases, anencephalics. And she's so well versed in this. And she's actually has a personal experience with donation her family member was a donor. And it's very personal to her, and it's not just about the organs, it's about the process. It's about helping the family heal. And that mother in Idaho, still in contact with this particular organ coordinator, and tells people how amazing the experience was for her to know that her baby helped 5 different babies from you. So it is great potential. So anyway, the donor usually, for a brain dead donor, is usually more stable because we're supporting them medically completely. We hope they are. You guys actually experienced a time when the donor wasn't stable, and there wasn't much we could do about that, and we actually lost that case as being able to be a donor. And we'll talk about her specific case and what happened. But multiple surgical teams are involved. So we have the heart doc, the lung doc, the liver doc, the kidney doc, if there's an intestinal doc, and usually the kidneys are the people procuring the pancreas. So we have 5 different surgical teams, plus our own surgical team in there. It's very organized. Flight plans are timed. We have a scheduled OR. Anesthesia is involved because they will paralyze and sedate the patient just like they would any other patient that's going for surgery. So the things to walk away with, remembering with a brain dead donor, is there's more transplantable organs, and you can take more time to be able to make this process happen and the family be able to cope and adjust. And it's not, we're just throwing this at you. So, showed you that slide already. Donor after circulatory death. So we already talked about the transplantable organs, or kidney and sometimes liver. We talked about that the donor must pass in 120 minutes. So the rest of it is something we haven't talked about. So with DCD, the donor must have good kidney function because that's what we're going for. We actually walked away from a case last week because we were ready, and we were getting ready to do a DCD, and the creatinine and BUN levels bumped hugely. And it was sick, like to the point where they probably needed dialysis or at least CRRT, the continuous renal replacement therapy. They're not transplantable at that point, so we had to tell the family, I'm so sorry, but they're not an eligible donor anymore. And that was hard for them to hear. But sometimes that happens. It's very rare, and this was a case of a drug overdose, and that can be sometimes the toxins from the drugs. And sometimes we're successful in flushing them out, most of the time, but this was not the case. So, donor registry requirements don't really exist here because they're not dead. They're not clinically dead until we pull support. So, this is all family driven. Every step of this is family driven. We ask if they consent. They have the right to stop before we go to OR. They have the right to stop before we extubate. They can do whatever they need to do. We tell them that. We're very transparent with this. But this has no registry requirement. It's a completely family-driven process. Anesthesia is not involved. And let me tell you why. So in the room, we have the coordinator, and the coordinators will guide all of this. He or she will tell you what we're going to do. We're going to pull the tube. OR is going to be ready. And they can't pull the tube, extubate, until the OR teams are actually scrubbed in, ready to go in the OR. Because that patient is going to be ran to the OR. We don't want that warm ischemic time. We don't want that cold ischemic time, so we're trying to reduce that. So that's why everything has to be in line. Once everything's in line, literally the coordinator is usually on the phone with the OR saying, okay, we're going to extubate. Extubation time is 14:02. And then we start the clock, whatever the defined time was, under that 120 minutes. And then we wait. So the person, when we pull the tube, we wait for 0 pulse pressure. We have the doctor declare. And then we wait, we go to the OR. We wait an additional 2 minutes in the OR to make sure the patient doesn't self-resuscitate. We have another declaration, and then we proceed. So it's a little bit different. It's a little bit of a rush. There's no anesthesia involved because the patient has passed. There's no need. The surgical teams are more in a rush to get things done appropriately. And the coordinator's a little bit frazzled because they're talking to everybody and making sure coordination happens and the time frame happens, and oh my goodness, what time did we go down, and did you know that, and do you know that? And the nurse that's supporting all of this is on point and in the room and involved the entire time, and usually helping push that patient to the OR. We need open doors, we need access, and we usually have access to all hospital, back, OR, everything, because of this reason. Do you guys have any questions about DCD? Yes?
Yeah, so is it 120 minutes to procure too? Like you have to have the organs out on ice in
No,
120 minutes?
till we start.
Okay. And
So
then
till
how
we
long?
start operating. So after that, it depends on the
Sure.
transplant center that's accepting the organ, how long they're going to give a time frame. Everybody's a little bit different.
Got it.
And it doesn't depend just on the transplant center, it actually depends on the recipient.
Sure.
So everything, I can't give you hard times on that,
Sure.
but that 120 minutes or defined below that starts before they're to the OR, when they're to the OR.
Got it.
They have to expire in that time.
Got it.
So that's the time where we extubate till we're waiting for that first zero pulse pressure. The first zero pulse pressure. Does that make sense? Any other questions? Okay, so let's move forward. Just tissue donation is where you guys are champions. I'll talk about numbers, but you guys had 58 referrals this year. 58 referrals that referred in donation, should I say. All of them became donation. Not all referrals, you guys referred hundreds. But the referrals that actually opted for donation consented 58. That's amazing. So, like we already stated, tissue donors can already be expired. There's a time limit, that's 8 to 24 hours. And so what you guys can do to help us with that, because we don't want to run out of our time in that 8 to 24 hours, we've got to obtain consent from the family, is a good family consent number, a family contact number, not consent number, so that we can talk to them. And it's all done over the phone. We don't have to be on site for these. Our TRS, our tissue referral specialists, they call on the phone. They're trained designated requesters as well. They know how to talk to the family, and they get consent, they get a history. And sometimes they don't get consent, and that's okay too. Family choice. The tissues that can be donated, we kind of already talked about heart valves with children. That's really big with children. With older people, we also take heart valves. Vessels, we take blood vessels, because if you're having a bypass graft and you didn't have your leg cut open so they harvested your own vein, you have a donor harvested vein. And that's impressive that we can utilize that tissue to help someone's heart beat better. This is skin graft, and this is a partial thickness skin graft done with a dermatome. And then we have full thickness that takes all the layers of skin, all the 5 layers of skin. So there's a difference. This is just the top layer, and we use the top layer tons for burn patients. If they didn't have that cadaver skin, they're more at risk for infection, for temperature control, and most often they would die. And what happens is they go into surgery all the time. Working at the U, I've worked really closely with the burn team. I've floated to the unit very often. I've been the nurse that has taken these grafts off. You put them on, you staple them, and you let the tissue heal. This is technically dead tissue, but you all have dead tissue. I mean, we're always shedding dead tissue. It sheds just like that. It will dry, it'll crumble off, and it will kind of fall off, and then you're removing the staples. And then underneath this, they're freshly granulated new skin. So that's kind of what that offers for burn patients. It's pretty amazing. And then bone and tendon. So if you have a patient that had a tumor grow in their bone, we can take their bone out, take the entire tumor with it, and give them a cadaver bone. And then they can still walk. There was a kid, I want to say he's from Wyoming, but he was cleaning a gun, and he was a shotgun, right? And he shot his shoulder off. Well, it was right here. And they actually were able to reconstruct with cadaver bones, so he has a bone. And he was 18 at the time. Can you imagine losing your right arm when you were 18? That would be awful, but he didn't have to because somebody was gracious enough to offer their bone to them in their time of death, which is what you guys do mostly. You guys offer these things to people, and that's amazing. So, this is a good point that we really need to talk about. This is what's called our guidelines for CMS that was set by CMS that we enforce, that I make sure that you guys follow, that I make sure that we follow. And this is, when do you call IDS? Like, when am I supposed to call IDS as the nurse? Well, this is your guideline. So you need to call IDS before approaching the family. That is actually CMS guidelines. That all comes down to the designated requester. CMS guidelines state we need a designated requester to be the person that approaches the family. That doesn't mean the nurse says, well, what do you think, donation? Not that you guys would ever say that. I'm like paraphrasing very crassly. But Or the physician. Physicians are not allowed to actually approach the family. Does that mean that we don't want them in with us when approach is done? Absolutely not. We want a collaborative approach. We want to make a plan before we approach the family with the physician, with the nurse, with the charge nurse, with the manager of the unit if possible. And then we can go in collaboratively. The nurse from IDS, the nurse from Memorial, and the doctor that the patients know. And we can talk about the options of donation together. The physicians, as well educated as they are, they don't do a lot of donation and they don't know the right answers all the time. That's where the nurse from IDS comes into play. So everything can come together and they can get the most information. It's not broken up, it's not wrong information, and the approach is done appropriately at the right time. Because that's another thing that designated requesters are trained to do, is to assess the patient, the family, and to see if they're even ready. If they're still hoping for a miracle, even though that patient is clearly brain dead clinically, but they can't emotionally accept that, and it's going to happen. There's a miracle, they're going to wake up, I just know it. They're not ready to be approached yet. We need to give them more time. So that's something the IDS coordinators will do. So, second part of that is we need you guys to inform us that you guys have someone that meets a clinical trigger within 1 hour of meeting one clinical trigger. That's considered a timely referral. If it is 2 hours, it's not considered a timely referral, and that actually goes against you guys for CMS. We're the people who kind of mandate, and I review all of your records. I'm the person who looks, and, well, we have report writers that do it, but ultimately I'm the final eyes on it and say, this is where we're at, and this is where you guys need help, and this is where you guys don't. I am pleased to say you guys had all referrals were timely. Every single one were timely. So congratulations on that. That is good, amazing. That's unheard of, which we want that to be. But usually there's always one outlier, one that's a non-timely referral. But you guys had every referral was timely. And I'm not just talking organ, this is also tissue. So, what are those clinical guidelines that we're looking for? We need a Glasgow Coma Scale of less than 4. Usually, nationally, most OPOs, organ procurement organizations like us, IDS, they look for a 5. We look for a 4. The reason being is because there's less there. We also want to see, not also, but if that's met, then you call. But another clinical trigger is loss of 3 cranial nerves. So if their eyes or pupil are pinpoint and they're not reactive, they are a lack of dull eyes. They don't have any pain response. You should call us. Any 3, you should call IDS. If your MD that you're working with is talking about withdrawal, I think we're done. I think it's time to withdraw on this patient. We need to talk to family. That's a trigger to call IDS. If the family's talking about withdrawal, I don't know if we can do this anymore. I don't know that we need to go on anymore. That's a trigger to call IDS. If the family requests information about donation, the best thing you can do, because ultimately you can't give them information without an IDS person there, is absolutely, I'm going to call Intermountain Donor Services, and they will be getting in contact with you as soon as possible. Let me see what I can do. That's when you call IDS. We are far away from you guys. 3-hour drive. So probably 4 hours, making sure that our organ coordinators get everything they need done before they head out. That's like max, but they can start over the phone too. And that's sometimes where we value and rely on the nurses that are bedside that have been working on that patient, because if it's imminent and we're like really fast and we're rushing to get there, and we'll fly if that's the case, but it still takes time. We might have you talk to the family for us with us on the phone, but we're still the requesters. But that's when we look to you to tell us, okay, IDS coordinator, I think the family needs a break. Can we give them like 15 minutes or 20 minutes and I'll call you back? I think they need a break because it's too much on them. That's where we rely on you. So those are some ideas that will play out. So the key points, you don't withdraw support without calling IDS. And you want to guarantee that you don't guarantee that the patient's going to donate by calling IDS. It's just a referral for us to evaluate for eligibility and if they're on the donor registry and if there is something we can pursue. If there is something we pursue, sometimes if it's like we're turning the corner and we're to the point where it's time to withdraw care, we'll be on our way. If it's, well, we're not quite sure, they meet one of the clinical triggers, but we're still doing interventions and the family has hope, then we'll say, okay, we're gonna call back and check later today or tomorrow. But that doesn't mean that if changes happen that you don't call us, because you should call us as well. Family's talking about withdrawal now. Okay, we'll be on our way. Or, okay, that's fine, they're really not eligible, so there's no point in pursuing for donation at this point. So it's one of the two. So, CMS regulations, we've kind of already touched on them as we've talked about the whole thing, so I'm going to just briefly go over. If you have questions, please ask me. So we have education and approach and consent. This is the designated requester asking the donor families. It's not the nurse, it's not the physician, it's not the manager of the unit, it is the IDS coordinator. The reason for this, again, is we've got to assess eligibility before we even give that option. If they're not eligible and they really wanted to donate, that's just another kick in the knees, right? So notification made to the OPO. When any trigger is met, we just reviewed that. So with that, I'm going to pass these around, and managers of the unit that you work on, I encourage you to take a few. Pass them out to your units. I don't need any back, so if you guys want to take them all, that's fine. So what this is a card that can hang on your badge, either way. That is our 24-hour referral line. And on the back is all of the previous slide that I showed you. That has all of the clinical triggers and what you need to do, that you need to call within that timely referral, call before the patient's extubated, call before the family's approached, call if any of these are met. So it's basically the previous slide right here, easy access, because nobody's going to remember that after seeing it once. Okay? So, takeaway points for CMS regulations so that you abide by them and that we abide by them. I am actually the person, CMS holds you accountable for these, but I'm the person that actually holds you accountable first to make sure that you're not written up by CMS when they do audit. So that's the idea behind these educations. Like, not that I'm going to sit there and hold your hand through this, but I'm going to make sure that you guys have the tools you know to utilize to make sure that you follow CMS guidelines. And this is what you guys need to walk away remembering. The hospital is required to refer. You have to refer. It doesn't matter if they're 85 or 0 or 99, you need to call and refer. Secondly, IDS staff are the trained designated requesters. You don't approach the family about donation. The physician doesn't approach the family about donation. Let us evaluate and do that. Yes?
So what about those families who, in their minds, their family member's not going to pass away, but we know that they are? And how do we get that conversation to go from us to you guys
That's a good question.
without causing some chaos?
So with calling us will be the first step. And then talking to us and and communicating those barriers is another way. And then when we will work with the physicians as well. Our IDS coordinators have great relationships with all physicians, mostly. They'll talk to the physician and they'll say, okay, maybe we can try this approach. And sometimes it's just giving time to absorb. And other times, but most of the time, I won't lie, it always comes down to time and evaluation and seeing what the physician is saying. Because sometimes it's not as clear. And I love physicians. I've worked with them all of my nursing career, obviously. But sometimes their outlook is so, I don't know the word, but like a neurologist can't talk to a patient very well. They come into a patient's room and they're like wide-eyed, I just saw a ghost. What in the heck did he just tell me? And then the nurse comes in right behind and says, so, do you understand what that meant? No. Well, let's talk about it. Right? And that sometimes is the key too. Because physicians sometimes talk in that clinical level and they forget to bring it down to that personal level. Whereas nurses, we're a little bit different. We're holistic thinking and we talk about that patient too. It's just not that diagnosis. So sometimes that's the difference, is that it's not as clear to them that like they're brain dead. They can talk about angiograph, or the angio scan is negative. The EEG is flatlined. But the patient's family might not understand what that means. So sometimes it's assessing what's been said. Does that make sense?
So then the physician can talk to the family about?
So what we expect from the physician is we expect them to give the grave diagnosis of this is non-survivable. We don't want them to talk about donation options.
Okay.
We do want them to tell them that the patient is not survivable. That's the difference.
Okay.
So they have absolute every control to tell me that my husband is brain dead, but he can't approach me to say, can I offer you an option of organ donation? Because that's not his role by CMS Guidelines. Her. That was her role. So that's really where it comes down to, is yes, they ultimately have to give that grave diagnosis to the family members and explain this is unsurvivable. But at that time, we're hoping that we're on scene and that we can let them process that for a few minutes, an hour, 2 hours, and then we can come in with the physician as well and the nurse and talk about the options of organ donation. We'd like to give you these options of organ donation during this difficult time. And we're never apologetic for offering. I'm so sorry, but I have to talk to you about organ donation. I'm not sorry about it. I am very pleased to be able to offer you the option to give your loved one's organs to someone to extend someone else's life from your loss. So that's another way of wording that we're really conscientious of, and that's part of the training of designated requesters. And we see often, I'm so sorry, but I have to talk to you about. And that's why we want to handle the request as well, because we don't want to act like this is a bad thing, because organ donation is one of the best things that we can ever offer for another person, and sometimes the family. We had a 4-year-old 2 months ago, Premier Children's son, died in an automobile accident. It was severed brainstem, pretty much. And the mother brought up donation to us, and the physician didn't want us to. It's not appropriate. I don't want you to talk about it. They've gone through enough. Why do you have to do that? Because he viewed it, and he put his own ethics into it, which you need to leave aside. Like, if you, whether or not you believe in organ donation or not, you have to put that aside to be able to approach the family. And that's something that physician couldn't do. And he really wouldn't let us talk to the patient until we said, you really can't not let us offer these options. Like, this is something you have to be able to let us do. And it's interesting because when Stephanie, our organ coordinator, went in and talked to the family, the mom and the dad was a little bit disconnected because he was in shock, quite frankly. Mom, on the other hand, are you kidding me? I can give her organs to someone? Oh my gosh, she can be a hero from this? I want that to happen. I need that to happen. I need that to happen. So, and that was literally what she said. So that's why we really want us to be the designated requesters, because we are also trained to leave our ethical and personal values out of it, even if they do have them. Whereas this physician couldn't do that, and he wanted to protect the family from organ donation. That's really what the one thing that the family wanted as a platform to start healing from this loss, this profound loss of car accident with one child lost. The mom's fine, and there was 2 other children in the car that had scratches, and then there's one that is dead. And this is their platform to heal, was organ donation, and the physician tried to not allow that. So that's why we ask as well. So yes, absolutely, grave diagnosis given. We have a severed spinal cord. This is a non-survivable injury. There's nothing we can do to help your child at this point in living. Support the family through that shock and that soccer ball to the stomach. And then we give them time, and then we go in and offer that option of donation to them. Does that make sense? And that's hard, and those are hard situations, and that's probably one of the worst to be in for any person, whether it be your child or your grandfather or whatever it is. But we still want to be able to offer the option, because sometimes that is the one thing that makes them feel the best in a tragedy. So, does that make sense? It's a long answer, but it kind of encompasses why. So, referral process, just to kind of give an overview, you have staff recognizes the 1 to 4 triggers. You call the donor referral specialist line. That calls call center, and then they page my organ coordinator on call that day. They will call the nurse back to get all the clinical information. So it's a little bit of a pathway. You call, they take the referral, they hang up with you, they call the organ coordinator, they give them the referral, and then they call you back. Because our organ coordinators are taking so many calls, and they're usually on a case when they're taking on the referrals, so they can't just take the initial referrals all the time. So it's kind of a way that we hired a professional call center to handle that. If it's a tissue referral, it'll go to our TRS instead of our organ coordinator, but the same process happens. It just happens on the phone with just the family members usually. Let's talk about you guys. I thought that's was a great opportunity to talk about numbers. Organ and tissue referral. So on the right side, or left side, you see organ. And it's small, just because there were only 3 referrals in the whole year, because that's what you guys were optioned to give us. But for all of those, they're flat across the board because everything was effective request, everything was a timely referral, and everything to match your total referrals. So it's flat across the board. There's not any deviation between the bars. So we've already talked about what a timely referral is. That's within 1 hour of those clinical triggers. What does effective request mean? Do you guys have any idea after this talk? I haven't really defined it for you as effective request is, but we've talked about it this whole time. It is that we were able to approach, not you guys. And that's what it comes down to. Effective request comes from IDS approaching and not hospital staff approaching. That's all it is. Simple as that. But we need to be allowed to do that. So, good news on that, 100% across the board. 100% for effective request, 100% for timely referral. With tissue, we have one little deviation with effective request. If you can see, it's kind of hard to see with the lighting, but this light green one is just a little bit lower than the other two. And the other two are even. There was one that was not an effective request. The nurse actually approached the family about donation, tissue donation, and told my referral specialist on the phone, the family's already told me they're not interested, I talked to them about it. Not appropriate. We can't have you guys doing that. Because you don't have all the tools that you need and all the answers that they might ask, and that's the reason why we ask them that too. I know that most of the time it's just out of, hey, I can just handle this for them at this time, they're right here, but we just, all that we ask you to do, especially in tissue cases, you know, you might have some phone calls about regarding your loved one. Can I get a great contact info number from you? Not even about donation, just there might be some people calling you. You could say from Intermountain Donor Services, that's fine. Can I get a good contact information? The Lions Eye Bank will also be calling. But we just need that contact information so that we can contact the family and let them know their options for donation. Okay? So, organ referrals, you had 3 referrals, all timely, all effective. So let's talk about who they were. First, the patient collapsed at work, the first patient. A large intracerebral hemorrhage was found. That's that hemorrhagic stroke we talked about. Patient was being evaluated for brain death or DCD at this time. This is the case that I talked to you guys about, was the one potential that was a really good potential of brain death or DCD that we could have done. The physician really wanted to do a CPAP trial, see where they were. We weren't, our organ coordinators was not convinced that that was the right thing to do at the time, but we moved forward with it because the physician needed that validation for themselves. We did the CPAP trial. After the CPAP trial was completed, the patient became very unstable very rapidly, very fast, and they coded. They were also considered a DNR, so no compressions were done, but we did try to resuscitate with adenosine, and we tried epi, and there was no success, and the patient did expire on the vent. And that was the reason why that didn't turn into a donor, is because she ended up not, the epi, everything was given and nothing could bring her back to be able to donate. She wasn't brain dead at that point. We were evaluating if we were going to wait for brain death or DCD, but she made that choice by expiring on her own. And that's okay. Sometimes that happens. Very rarely. Those cases very rarely happen, but that's why you guys don't have one donor out of here. They were all just referrals. She would have been the one donor, and you guys did everything you should have done. It was nothing for error. It was just, that's what was chosen by fate, I guess you could say. So, any questions about that case? And I'm sure some of you, like I had some nods when I started talking about it in the beginning, have been on this case, or worked with this case, or read about this case, or so if you have questions. If not, that's fine. Oh, second, the patient was found down at home, not found for a few days. He had a brain, or a developmentally delayed son that he was sleeping for 2 or 3 days. I can't remember if it was 2 or 3 days. He still had a pulse. He was brought in. Because of his health status, he wasn't eligible to be a DCD, and he was not brain dead. So we walked away from that because he was not eligible. Third patient lived in a care center. Respiratory failure came in, intubated. He was not brain dead, just couldn't breathe and wouldn't breathe on his own because he had COPD so severely, and he was older. He was like in his 80s, and he was ruled out for DCD due to his age and was not brain dead, so he was not an eligible donor. But it was a referral that was made perfectly, and they should be made. And we're the ones who evaluate, and we decide if they're eligible, and this is a perfect situation for them. Okay? Any questions on those two cases? Okay, so again, we already talked about these numbers. I'm sorry, I said 58. You guys had 59 referrals. 59 timely referrals, only one was not effective. We talked about that. 98% effective. That is awesome numbers. We want you guys to be above 95. Well achieved. Very well achieved. Just a little bit of another way to view this card that I passed out. Glasgow coma, intubated, ventilated, end of life care. You guys think about those things? That's your patient. Give us a call. Any questions about any of the presentation? I know it's a lot of information at once.
That was very helpful.
Okay. So, secondly, I'm going to give these to you as well, Karen. But managers who left, if you would be so kind to give them my card. I really want you guys to be able to get a hold of me if you guys have questions. You guys are frontline people, and my email is always open. My phone is always open for messages. I'm not in the office a lot, but my email comes to me outside of the office. My phone does, but the app is not very reliable. You guys are welcome to take these cards, pass them around, take a few to, I'll just pass them, I'll give you a chunk of them, to the managers that did leave the unit, or did leave the in-service for their units. I really want the managers to have one. I'm here as a resource for you, just like Woody has always been. I know you guys will miss Woody. I know I have big shoes to fill literally and figuratively, but I plan on doing that for you. And I'm excited to be able to work with you guys and achieve great things in collaboration. I would love for you guys to think more about those clinical triggers, get more referrals, let us evaluate more potential organ donors. We want you guys to be able to handle the organ donor instead of ship them to the U or ship them to IMC. Ship them is a cold word, but that's what everybody says, isn't it? But that's ultimately what we want to do. So we want to try to support you through that process. If you have an organ case come up and our coordinators come on site, it'll be most likely that I come on site. And the reason why is to support the staff. The organ coordinators are busy supporting the patient and managing the patient and allocating organs. And there's a lot of questions, and you guys don't see this very often. I want to be here to help you. I probably won't be here like the organ coordinators are here 24 hours at a time. I won't do that because I work, they have more days off a week than I do. Let's put it that way. But I plan on trying to be here with those cases as long as there's not something else going on in Salt Lake area, in Utah area, or Idaho that I'm already at. But that's my plan. So if something's happening and you guys need some support, that's when you call me. Email me. If something's not happening and something did happen, you have questions like, I'm not sure if this was potential or not. I'm not sure if we should have called you. Let me talk to you about this. And I can tell you, well, this is right and this is wrong, or whatever happened. So that's kind of where I come in for you guys. Okay? Yes?
Sorry, when you guys came the last time, we have a lot more new people than
Yeah.
when you first presented to us. From the OR standpoint, were you saying like it'll be the call team who obviously gets called for this, and it usually happens, they said usually late at night kind of a thing. So it's only a scrub and a circulator
That's required.
that's
to be
required to be there, and an anesthesiologist if applicable, right?
That's correct. Absolutely. So we do require the circulator and one scrub, and then we bring up the rest.
Okay.
Mhm. And we have our own scrub techs, and we have our own circulator, kind of. They're the organ coordinator as well. But they are also doing so much more. That's why you need that circulator for your OR who knows where everything is, and that scrub, same difference. The rest of the surgeons come with the team that they're collecting the organ, I guess, is the way to word it, which isn't very...
Do you bring your own equipment too, or like you just come with a list of things you need us to get? Is that hard?
So usually they will, so if it's tissue is a little bit different. They're already deceased. If they're collecting here, they usually do that at the coroner's office. But they will bring their stuff usually unless they've already talked. They're going to communicate with the OR what they need before they come. But usually they'll bring what they need, or they'll tell you what they need before. It just depends on case by case and where they're at the time frame, but they will communicate with you beforehand. So, OR is a little bit different than all of this other floor stuff. But our biggest thing is we like to work with you guys. The DCD cases are a little bit tenuous in time frame. And sometimes it's the family driving and saying, I can't do this past 11 a.m. So we need an OR time before that. And sometimes that's hard because I know you guys have a busy OR time, but by CMS guidelines, you need to try to make that happen. And sometimes it's the fact that we don't think the patient will be stable long enough, and we need to get the OR time so that we can offer that donation to the family. And sometimes I've had my organ coordinators refer to it as, we're going to lose these organs. It's actually not. It never comes down to the fact that we're going to lose these organs. It's actually about doing what the family wanted. We're actually, especially in a DCD case, the family's driving this and they could stop at any time, but this is what they want. And so it's usually about the family process. We just really need this done to help the family get through with this so that they can move forward. And sometimes when we're in the back end and we forget how to word things appropriately, it's said a little bit wrong and some staff can take that wrong, but it's never about just the organ. Like, we're not about organ. Like, yeah, absolutely. We're an organ procurement organization. But we don't just focus on the fact that we're here for organs. We're here for the whole process. And I want you guys to remember that. Like, even if you have some comment about just we're going to lose these organs, it's not what we're talking about completely. And there's a whole process behind that. And sometimes they've got so much going on. It's just like an ICU when things are crashing. Sometimes things aren't said as eloquently as they should be. So, but that I've had ORs get kind of tussled from those comments recently, and so I wanted to bring that up before. Just saying, like, sometimes just remember we all owe each other a benefit of the doubt in verbiage. Sometimes it's not said the most proper way, but ultimately the goal of IDS is to make sure that we encompass the family needs, the patient needs, the recipient needs, as well as you guys and our coordinators, but they're the people who make everything happen. So okay, does that make sense a little bit? Okay. Any other questions?
I have a question, Amber, and this may be a little more complicated, but how about patients we have a lot of behavioral health patients, some who are titled, so have lost their rights, but they're an organ donor and they're in a pass. What's that kind of situation with you guys, and then how about coroner's cases?
So they're still referred, and they
Okay.
still should be referred to us. And then it kind of comes to the IDS coordinator's responsibility, working with the family, the hospital to find the family. If they're registered and we don't have family, and there is no family, then we can proceed. Coroner's office, usually that comes down to tissue cases because they already have passed. And we work really well with coroner. In fact, I met the coroner, Dell, before I met you guys, and that's kind of why I was 5 minutes behind coming down here. But and I probably walked past you in the lobby. But I met with him to actually talk to him about signing some policy agreements.
Okay.
We have a great relationship with all the coroners, all county coroners, not just, but I'm talking about Dell here in this county, but they work with us very well, and we usually go into the coroner's office to procure the tissue and work with them on that regard, and family, again, is involved in that process as well. We don't just take tissue. It's a consented. If we can't consent, it's not done.
So no matter what kind of situation, we call you and you guys decide if you can
Yes.
intervene. Okay.
Yes, absolutely. So, and you guys have a lot more coroner cases probably than other hospitals, just the nature of the residents in Sweetwater. So, coroner is a great resource as well, and he works very well with us, and he's always been a great support. He used to actually do the procurement of ice years and years ago. He was just telling me, and I didn't know that until just now. So, very, very good resource as well. And so if you guys have more questions, coroner-wise, what process they expect, he would probably be happy to talk to you about it. And I'm always even though it's Salt Lake away, but it's really literally, I'm here for you guys whenever you need me. So, okay? Anybody else? Well, I want to thank you for your time. Thanks for spending the time of your day, coming in on your day off, learning about organ donation and what you guys can do in your hospital. It is a profound impact you guys can make. And I don't want to leave without saying thank you for taking the time to learn about the impact you guys can make for other people that still have life to live. So, amazing results from this year. I know that 3 doesn't sound amazing, but the fact that you guys had 100% timely, 100% effective on all your organs, there was only 1 not effective case for 59 for tissue. Major props, congratulations. I appreciate your work and your effort, and so do the people that received all those tissue and can have a extended life from that. And I can't say it extends life. Sometimes it does, like heart valves, but it's definitely a life-enhancing donation. So,
Well, thank you for coming.
thanks you guys.